Thanks, Dr. Chris Runz, for talking to us about urology training and the robots. Urology training, in my mind, I imagine it underwent a lot of change. First of all, when laparoscopic stuff came along, and then again when the robot came along. What do you think has been, or what have been some of the bigger changes in urology training in the past 10, 20 years?
Yeah, sure. Well, the robotic interface has probably been the most dramatic change in urology here since 2002. The Da Vinci robot really came out and was actively used really in Detroit initially back in the year 2000, and it really revolutionized training programs. Most residents coming out now have experience in robotics, and many of them ultimately go on and do fellowships in, as oncology and minimally invasive laparoscopic and robotic surgery. Urology is unique because of where we operate. We operate in a very small, confined area of the body, the retroperitoneum and the pelvis. And there are a number of critical structures back there that we need to avoid. There's large blood vessels, as you know, there's critical nerves and pedicles, and then there's a lot of reconstructive work. Doing laparoscopic work, whether it be a partial nephrectomy, ureteral reimplantations, UPJ obstructions, and of course prostatectomies, doing that laparoscopic is quite challenging. There is a significant learning curve to that. And what the robot does is it's sort of the great equalizer. It gives us the attributes of open surgery: 3D vision, 10x magnification, tremor control, scaling of motion, and it allows us to do it laparoscopically. So the patients really do so well. Mm-hmm. The primary application there, as you know, though, was in prostatectomy, and it really has become the way to do prostate surgery or prostatectomy today. Mm-hmm. Really, there are very few urologists today that do enough open radical prostatectomies and still have very good results as far as cancer control, continence, and return of erectile function or potency. What we like to refer to as the triad. Right. Do we have, are we perfect in all three of those areas? Mm-hmm. And robotics really improves that for us. So I think that's been one of the biggest changes. Also in urology has been the use of lasers, and the use of endoscopy, and the optics in endoscopy for ureteroscopy and scopes has really literally improves almost yearly.
Mm-hmm. Do you think most programs have a robot then that do urology training?
Yeah. Most of them do now. Now, when I was a resident and I graduated in 2005, we had one robot at one of our institutions. And as I graduated, we had a second. But at that point, really, the attendings were really just getting comfortable doing these procedures. We didn't have a whole lot of exposure initially. Today, almost all urology training programs do have robotics, and their residents are being trained at least in robotic prostatectomy, if not ultimately partial nephrectomies as well, and reimplantation.
Mm-hmm. Now, are there fellowships for people who want to get more training, or are people typically trained and done by the end of residency these days in robotics and urology?
Really, yeah, there are a number of fellowships in advanced laparoscopic and robotic training in oncology. If you're going to be doing partial nephrectomies, really, most of the people that are doing the large volume, the real challenging tumors, the endophytic tumors, the tumors that are around the renal hilum, these are usually fellowship trained individuals. But I can't speak right now, what kind of true hands-on experience urology residents are getting with the challenging partial nephrectomies. But robotic prostatectomy is a mainstay. And a number of the residents that I know that have graduated in the last 2 and 3 years do come out fairly well trained in robotic prostates.
Good. General surgery, of course, is looking for angles to use the robot, and I wonder about the lessons learned from introducing it, sort of all over the country, and a hospital will get one that they're using for urology, and surgeons sometimes will be pushed to use it for other indications. I know in obstetrics and gynecology, they had a run with it, and then they've been backpedaling a little bit about its indications. The same thing in general surgery in terms of thyroid and parathyroid. So what lessons can we learn from the experience? I would say, in my mind, urology sort of led the game in using robotics and as sort of one of the mainstays in their typical cases.
Yeah, this is a great question that's being addressed in every robotics program across the country. I'm the director of our small robotics program, and we don't have any general surgeons. It's mainly urology and gynecology using our systems. But that's a great question. My personal opinion, and I think what most robotic surgeons will tell you, is you don't need to use a near $2 million robotic platform to do something you can do fairly routinely and easily laparoscopically. In general surgery, that may be gallbladder surgery, and I know there's a big push for single port access for gallbladders. But using a robot doesn't make a whole lot of sense from a cost, a time and setup standpoint, when it can be done just as equally and very well purely laparoscopically. That debate is actually ongoing right now in gynecology, as you're probably aware. Should we be doing benign hysterectomies that are routinely done laparoscopically assisted vaginally, transvaginally, in docking a $1.8 million robotic system with the added disposable costs? Should we really be doing that? There are a lot of different issues going on there. There's patient demand. I'm going to go to the gynecologist that does robotics because of the perception that they're doing a better procedure. So it affects business. So part of that has to be taken into consideration. But when you start looking at other applications, especially in general surgery, again, it is best for reconstructive work, detailed work in small confined areas. Now, I know it's being used on esophageal surgery, Heller myotomies, Nissen fundoplications, and then with bariatric work. And I think that there's certainly advantages there. You really have the ability to do the procedure you need, to do the reconstructive work, and perhaps have less injury to the esophagus.
That wrist becomes important.
And I think that there are certainly advantages there.
I've had esophageal surgeons tell me that wrist becomes important when you're, particularly during redo surgery of the esophagus, Nissen fundoplications. How about the cost of those machines? Have they been coming down, or do you know what the cost is?
Well, the cost of the Da Vinci system, has not really been coming down. I mean, what needs to happen and what will happen eventually is everyone's betting or trying to bet on the competitor to the Da Vinci system. There will be another robot. And there are about 6 of them currently being developed, from Germany to England to Canada, the Koreans, the Japanese as well. So the real question is who's going to have the first competing product on the market. And when you finally see that happen,
then
and it will happen, you're going to see costs dramatically drop.
I hadn't thought about that. That's right. So far, they're the only ones up and running that I know as in pretty common use.
Yeah, they have a monopoly worldwide, and it's a great product. But like anything, you need competition and innovation, and it'll happen. It'll drive down cost, no doubt.
Right. Well, thanks for talking to us. That perspective of the urologist is interesting as we start to look at how to use robotics in general surgery.
Thank you.
Talk to you again soon. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.